The subject lies supine with the test knee in 30 degrees flexion and the ankle in neutral plantar flexion / dorsiflexion and inversion / eversion. The examiner grasps the subject's distal thigh posteriorly with the proximal hand and the subject's ankle from the plantar surface with the distal hand. With the proximal hand stabilizing the subject's distal thigh, the examiner maximally externally rotates the subject's lower leg, maintaining the ankle in neutral position, and measures the amount of external rotation created between the knee and medial border of the foot. The test is repeated with the knee in 90 degrees of flexion. An increase of negative 10 degrees or less than 10 degrees of external rotation as compared to the contralateral leg at 30 degrees but not at 90 degrees is indicative of an isolated posterior lateral corner injury. At less than 10 degrees increase at both angles is indicative of injury to both the posterior lateral corner and posterior cruciate ligament. The subject lies supine. The examiner stands next to the involved side and cups the subject's foot in one hand. The examiner's other hand may be placed over the joint line of the knee. The examiner passively flexes the subject's knee and then allows the knee to passively fall into extension. A rubbery infield or springy block is indicative of a meniscal tear.
The subject lies supine on the table with both the hip and knee at the involved side flexed to 90 degrees. The examiner passively stabilizes the positioning of the subject's hip and knee while assessing the location of the tibia along the longitudinal axis. The recognition of one tibia resting more inferiorly than the contralateral side may indicate a posterior sag or instability. This may be related to posterior cruciate ligament. The subject lies supine with the test hip flexed to 45 degrees, knee flexed to 90 degrees, and foot in neutral position. The examiner sits on the subject's foot with both hands behind the subject's proximal tibia and thumbs on the tibial plateau. Apply an anterior force to the proximal tibia. The hamstring tendon should be palpated frequently with index fingers to ensure relaxation. Increased anterior tibial displacement as compared to the uninvolved side is indicated of a partial or complete tear of the ACL. The subject lies supine with the test hip flexed to 45 degrees, knee flexed to 90 degrees, and foot in neutral position. The examiner sits on the subject's foot with both hands behind the subject's proximal tibia and thumbs on the tibial plateau. Apply a posterior force to the proximal tibia. Increased posterior tibial displacement as compared to the uninvolved side is indicated of a partial or complete tear in the PCL.
The subject lies supine. The examiner stands and grasps a great toe with each hand. Lift both legs off the table vertically by the great toes. An increase in hyperextension and external tibial rotation as compared to the uninvolved knee is indicative of posterolateral rotary instability secondary to damage of primarily the PCL, LCL, posterolateral capsule, and arcuate complex. The subject lies supine with the knee in full extension. The examiner places the proximal hand under the involved knee and grasps the ankle with the distal hand. The examiner passively moves the subject's involved knee into various ranges of knee flexion, followed by a dynamic movement into internal rotation and external rotation. A subject who either complains of pain during the rotational component or lacks full flexion may have a meniscal tear.